Good morning, everybody. Welcome to Untangling Amyloidosis 2023. I'm Jeffrey Zonder. Don't seem to be able to, there we go. I'm Jeffrey Zonder from the Karmanos Cancer Institute, and I'll be moderating today's session. This is our fifth Untangling Amyloidosis symposium, and I want to thank our planning committee for their incredible assistance in putting this together. These meetings are an incredible amount of work. Thank you to Andrew Kinn, our program co-chair, and especially to Christy Hood, who was heroic during the planning of this symposium, and without you, this could absolutely not be taking place this year. So thank you so much, Christy. These are the planning committee disclosures. And here are the objectives for today's session. Today we want to help the audience to understand how to accurately diagnose and assess prognosis of AL amyloidosis. We're going to discuss the criteria for autologous stem cell transplant as therapy for AL as part of one of the lectures and then in discussion afterwards. And we're going to provide data to help formulate evidence-based therapy. We're going to talk about best practices regarding cardiac imaging of amyloidosis, and in order to do that, we're going to be talking about both AL and ATTR amyloidosis, and we're going to talk about the therapy of ATTR amyloidosis. As hematologists, we don't always manage that. In fact, we often don't manage it. However, the therapeutic successes in that clinical area have relevance for future potential therapies in AL amyloidosis, and so we want to talk about that. And then finally, we want to talk about one of the complicated issues that we face in patients with AL amyloidosis, which is abnormal bleeding or clotting complications. And we have a great talk planned for that. This is the agenda for today, and the speakers who will be covering all of these topics. Very excited about our panel today. Eli Mukhtar from Mayo Clinic, Dr. Giada Bianchi from Harvard, Laura Okbici from Pavia, and then we'll be rounding it out with a talk from Dr. Rafat Abenauer from Indiana. There will be a question and answer session, a panel discussion that'll be about a half hour at the end of all the talks. People will have the opportunity to step up to microphones and ask live questions, but there is also an online an audience response system that you can access with your devices. I'll tell you a little bit how to do that, but you can also directly text us questions that we will see up here and that we can address during that panel discussion. I want to thank the sponsors of the symposium. The CME is provided by Wayne State University and the Karmanos Cancer Institute. I want to, in a heartfelt fashion, thanks the nonprofits who've supported this, the Amyloidosis Foundation, Amyloidosis Support Groups, Amyloidosis Speakers Bureau of Mackenzie's Mission, and also I want to thank the Amyloidosis Research Consortium for their promotion of the event through social media. This event was supported by generous educational grants from Janssen Biotech, by Prothena, and by Alnylam Pharmaceuticals, and without all of you, also, this could not be taking place, so thank you all very much for your support of this. This is a CME event that is designated for a maximum of 2.25 AMA PRA Category 1 credits, and people who are, I thought we removed the the animation. People who are present, attending today, we would like you to claim your CME within 7 days of the event, and that can be claimed online. And if you have any questions regarding claiming CME credit, Christy Hood, email shown here, can answer any questions that you might have to help you with that. As I mentioned, we do have questions and comments that can be submitted directly via the online link. On your table, there are QR codes, and one side is the QR code for the post-symposium evaluation, but the other QR code is for the audience response questions and for asking your questions. So you are using your own device, so please use the camera on your phone to scan the QR code so that you can be prepared to participate in the questions during the symposium. This is also the QR code, but it might be easier to use the one on your table. I'll keep it up for just a few seconds here. And we are going to go through a few audience response questions now to help us understand who's in attendance today, but also to help you understand how to use the ARS system so that you're ready during the presentations to answer the questions. So let's start with question number 1. Which of the following best describes your title or employment? A, hematologist-oncologist, and this includes trainees, fellows in that area, physicians in other specialties, including residents or fellows, mid-level provider, such as a nurse practitioner or physician's assistant, a nurse, or a pharmaceutical company employee. So we'll give you 15 seconds to answer this first question. Okay, so here are the answers, and we can see that most of the attendees in the room are physicians, about 3/4, and also representatives from, my audio definitely sounds a little different now. I'm not, does it? Okay, all right. We'll go on to the next question, please. Which of the following best describes your practice type? And this is going to be relevant to the physicians and nurses and nurse practitioners. A, comprehensive cancer center or university hospital. B, community hospital with an academic role. C, a community hospital without an academic role. D, bench or translational research. E, other. Mm-hmm. And I think not surprisingly at the ASH meeting, most of the attendees at this session are academically inclined clinicians, including about half of people at universities or comprehensive cancer centers. We'll go to the next question, please. How many AL amyloidosis patients have I personally treated in the last year? I don't think that necessarily means new patients. I mean, how many patients' care have you been involved in the last year? A, 0, B, 1 to 3, C, 4 to 6, D, 7 to 10, E, more than 10. All right, so a mixed level of experience, some quite experienced, and some who only occasionally see a patient. And one of the goals of this session is going to be to help, all learners in this audience with management questions. So I think the format of today's talk is going to be suited for the sort of the diverse experience that people in the audience have. And then I have one last question. How many ATTR amyloidosis patients have I personally treated in the last year? A, 0, B, 1 to 3, C, 4 to 6, D, 7 to 10, and E, more than 10. And this is my last question, and I think this answer isn't particularly surprising. I think that most hematologists don't treat ATTR amyloidosis, but there are probably center-specific reasons why people do, and so we do have some who treat a few ATTR patients, and a couple of people, and I know who you are. I'm looking right at one of them. I know who you are who treat quite a number of ATTR patients. So with that, our practice questions are done, and I'm going to now introduce, if I can, introduce our first speaker, Dr. Eli Mukhtar from Mayo Clinic, a fantastic colleague and a true expert who's doing great work in the field of amyloidosis. As you'll hear, some of that work is related to making the diagnosis, but particularly focused on prognostic factors and assessing response. And I can't think of a better person to be talking about this than Dr. Mukhtar. So thank you.
Thank you, Dr. Zonder, for this kind introduction, and I'm very happy to be here. And thank you also for the generous invitation for this symposium. So my name is Eli Mukhtar. I'm from the Division of Hematology at Mayo Clinic, and I will be discussing making the diagnosis of amyloidosis and assess the prognosis. These are my disclosures. And for the specific objectives of this talk is to educate about the importance of making a timely diagnosis in this disease. We'll learn about the diagnostic techniques to secure the diagnosis and also discuss the prognostic factors in this disease. As far as the journey to diagnosis, this is different between patients. But generally speaking, the journey is not a straightforward one for many of those patients. You can look at this data from this online survey. Most of the patients need to endure more than 6 months until the diagnosis has been made since their initiation of their symptoms. And for a large portion of patients actually count in years. And during this time, they are seeing multiple physicians, sometimes from different disciplines, undergoing diagnostic testing. Some of them are very comprehensive, and then being told that everything is okay, they haven't found anything, while their symptoms are actually getting worse. Or they are being given diagnoses such as renal failure or congestive heart failure, which are not very specific and not very helpful in promoting the treatment of those patients. Or they're getting a misdiagnosis. I've seen several patients being diagnosed with asthma when they have shortness of breath on exertion, or very commonly CIDP for their peripheral neuropathy. So they are being given a false hope, and in addition, that further delays their diagnosis. It is important to understand what are the barriers for making a timely diagnosis in this disease. And the first barrier is the patient perception of their symptoms. Many patients, especially at the beginning, because symptoms are usually gradually increasing, they think that their symptoms might be related for process of aging. I'm just getting old. Or they think that those symptoms may go away. It's like a temporary, it's like a flu. Or it might be a side effects of their medication. So this is the first barrier. But once they cross this barrier and they come to seek medical attention, then the major barriers are within the medical system. The symptoms of amyloidosis, and unfortunately I cannot describe it too much in this discussion, are not very specific. And given the fact that the diagnosis is not very common, that pushes down amyloidosis in the differential diagnosis list quite down the list. So it's really not coming up as one of the first things that physicians think about. Now, the presentation of amyloidosis is quite diverse. There are multiple presentations, and because of that, there are multiple entry doors for those patients. They can go through the cardiologist door or pulmonologist or the primary care or hematologist. And it's important who sits behind that door. Is he or she are aware of amyloidosis? Have they seen patients with amyloidosis? Have been know how to work patients with amyloidosis? Those are things that would determine the course of those patients. And last and not least is the requirement for tissue diagnosis. There is no such thing as clinical diagnosis of AL. You need to confirm the diagnosis on a tissue biopsy that need to be obtained. This is not kind of a tumor or a lesion. This is kind of a random biopsy from the tissue. And until this tissue diagnosis has been made, you can't really say that the patient has amyloidosis. So this is another factor that delays diagnosis in this disease. Now, we say that AL amyloidosis, and specifically AL amyloidosis, but other forms of amyloidosis as well, is a race against time, and we need to shorten the time to diagnosis. And I want to explain why. It's really important to understand why early recognition is so important in this disease. As I was alluding to, amyloidosis is a progressive disease. So early diagnosis will mean that the patient will be diagnosed at this stage when there are few symptoms and only mild organ damage occurring at that time. We can offer more treatment options for those patients, and also importantly, we can reverse the organ damage. But if diagnosis is not made at this golden hour, symptoms will progress, and some patients will progress quite rapidly. Patients become quite symptomatic. Basically, their end-stage organ damage can be in multiple organs, and this is a point of no return. Whatever treatment that you will give to those patients, you cannot alter their natural course of their disease, and most people will be dead just because we haven't diagnosed them early enough. Now, we always try to educate and promote early diagnosis, but we need to think about maybe other ways that will allow us this early detection. And this is kind of 2 slides about artificial intelligence and how it can maybe help in making this early detection. So this is an AI ECG. This is an algorithm that was developed at Mayo Clinic. It wasn't developed specifically for amyloidosis, but it was included cardiac amyloidosis as well. So this algorithm was trained on hundreds of thousands of ECGs. Some of the ECGs from patients with no cardiac diagnosis, and some patients were with certain cardiac diagnoses, including cardiac amyloidosis. And the algorithm was able to detect changes in the ECG. Most of them, by the way, are not visible to the human eye, that will distinguish cardiac amyloidosis from other cardiac diagnoses and normal ECGs. And it provides a score from 0 to 1. So 0 is the lowest probability of cardiac amyloidosis, and 1 is the highest probability. And each dot represents a different ECG, and this is the timeline. So this is a patient of mine diagnosed in 2020 with cardiac amyloidosis. This was AL type, but she presented a year earlier to her primary physician saying, I have pain in my arms when I have a long walk. And that primary physician ordered an ECG, and the ECG was read as normal sinus rhythm, so no further cardiac workup was done at that time. And eventually, she added the cardiac workup a year later. Now, at that particular time, this AECG was not available. This is a retrospective look at the ECGs from that time. But imagine that this AI ECG was available for that physician. He could have looked at that and maybe ordered a test and make the diagnosis 1 year earlier. Now, if we want to look at it in a broader sense, not only on the ECG, because this is more specific for cardiac amyloidosis, maybe we can harness all the information stored in the electronic health records to create, through a process of machine learning, understanding the phenotypes that can be taken out from the electronic health records, and create a screening model that will help to understand that a patient that you just saw may have amyloidosis. Now, an important step in this process is identifying the signs and symptoms of AL amyloidosis from the electronic health record. So we have signs and symptoms, those are important. We have imaging, we have testing. Now, this is a crucial part because we need to train the computer to understand human language. And so in this study, there was it's called natural language processing, or NLP, for those who are interested. So an NLP algorithm that is specific for amyloidosis was created These are 15 signs and symptoms of amyloidosis, including dyspnea and edema and neuropathy. And the investigators looked at the ability to abstract the data from the EHR using this NLP algorithm versus a person manually abstracting the data. And this is the performance for one of those signs and symptoms. This is specifically for proteinuria. And you can see that the AI-based approach and the registry, which is the manual abstraction, had pretty much equal quality of abstraction of the data. But obviously, using an AI-based approach is much more time efficient and cost effective. So once we cross this barrier, we have an LLP algorithm, we can now incorporate it into a model that will screen with other things stored in the electronic health records to create a model that will alert the physician about the possibility that the patient may have amyloidosis. Now in the second part, we'll discuss about the making of the diagnosis. So when should we suspect the diagnosis? Now it's hard to put in one slide the multiple presentations of amyloidosis because there are truly many. But we should focus on the things that are usually commonly seen in this disease. This is kind of the first start. And these are, I put in those here, and you can see them, patients with persistent proteinuria that has no other alternative explanation, patients with heart failure with preserved ejection fraction, patients with neuropathy, patients with hepatomegaly, and also patients with monoclonal gammopathies, MGUS, motoring, myeloma, Waldenström macroglobulinemia, that have a typical presentation. Now, it's hard to say what is exactly atypical, but for example, if a patient with Waldenström presents to your office and has a profound edema, then maybe you should check 24-hour urine, or maybe you should do an echocardiogram, maybe searching for the nephrotic syndrome or his heart failure. Now, as far as workup, it really depends on where the patient starts and what are the symptoms of those patients. And we won't discuss it because it's really might be a long discussion. However, there is a common pathway for screening patients with AL amyloidosis, and this through the use of the monoclonal protein studies. We have 3, and those are listed here. And we know that all patients with AL amyloidosis will have at least one abnormal study. So if all testing are being ordered and are negative, we pretty much can rule out the diagnosis of AL amyloidosis. There might be some other forms, but AL amyloidosis, it's very, very unlikely to happen. If it's positive and you are suspecting amyloidosis, you cannot make the diagnosis. You need to confirm the diagnosis. And this is using a tissue biopsy, which shows the congregate positive deposits, the amyloid deposits. Now, we can go into the organ that is affected and get the biopsy from that, but we prefer less invasive biopsies. Obviously, it's less risky to the patient. It is less costly. And in AL, this is specifically true because we can find the amyloid in more accessible tissues, and this is the bone marrow and the fat aspiration. If you look at this pie chart, 90% of patients with AL amyloidosis will have amyloid deposits either in the bone marrow or in the fat. So it's only really at 10% of patients, if you order the bone and the fat, and there will be negative in those 2 tissues, then you need to go into the organ and get the biopsy from it. We know that men and patients with limited organ disease are more likely to require organ biopsy, but also look, lack of fat aspiration. So close to 20% of patients are marrow negative, fat positive. So if you don't do the fat, then you need to go into the organ and get the tissue from that. So we definitely can spare for most of the patients the need for an organ biopsy. Now, once we have demonstrated the amyloid deposits, we haven't finished our diagnostic process, and the crucial next part is the typing. And I say it's crucial because therapy is guided by the type that we determine. We don't have a pan-amyloid therapy, at least not today, maybe in the future. So we need to know the type because we need to guide the therapy based upon it. And typing must be done on the tissue. We cannot assume that if a patient has amyloid and has a monoclonal protein in addition, that this equals AL type because you will be wrong in some of those assumptions. So again, typing must be done on the tissue. The gold standard is using mass spectrometry. And we say it's a gold standard because the quality of the data that we're getting from this typing. So what happens is that the amyloid deposit is actually microdissected from the tissue, and then it's been goes through some chemical degradation using trypsin, and then there is a sequencing of the peptides that are received from that amyloid deposits. And using a library and a software, the laboratory can determine the protein composition of the amyloid deposit and what is the leading protein which causes this amyloid deposit. So it really is a very accurate method of typing. Now, it's not available in most centers, although many do send it. So if you have ability to send it, that probably will be the best way to do typing in amyloidosis. The other options that we have are the antibody-antigen typing methods. This is, for example, immunofluorescence, immunohistochemistry. They have higher false positive and false negative results. So if you're using that, it's better that it will be used in a laboratory that is skilled to minimize those false results. Now, once we secure the diagnosis of AL amyloidosis, we need to do workup that goes into two directions. We need to assess the what is the organ that are involved in that patient, and we need to assess the clonal disease. As far as the organ assessment, what I put in the upper box is things that are routinely done because because those organs are quite prevalent in this disease. Heart and kidneys are seen in 16 to 80% of patients, so it very makes sense to screen those two organs. So for the heart, we're doing ECG, echocardiogram with strain, cardiac biomarkers, NT-proBNP or BNP, and troponins. Those are important because we can determine the stage, and we'll discuss it in a minute, but also we can assess using those parameters the response to therapy. So those are really important to obtain at baseline. Some patients, it's hard to determine if they have cardiac involvement, and this is where cardiac MRI may be helping you. For the kidneys, we're doing creatinine, albumin, and 24 urine protein. Again, this is important first to determine if the organ is involved, but second, to assess the response if the organ is indeed involved. We do screening for liver and coagulation profile because those are blood-based testing, those are prevalent, and it doesn't cost a lot to make those. So alkaline phosphatase, bilirubin, coagulation profile, known is factor 10, but there's actually more than just that. We'll hear from Dr. Abnur about that. So once we finish this, and there are other tests that might be done based on the clinical presentation of the patients. If you suspect autonomic involvement, or if you suspect GI involvement, you can do some more testing to verify. We also want to understand the clonal disease, the underlying clonal disease. So this is using the monoclonal protein studies that may have already been done because you've been suspecting the diagnosis. And those are important because, again, they will be used for assessment of response, so we need to get that baseline close to the diagnosis. And also a bone marrow biopsy because we need first to understand what is the underlying clonal disease. That's typically a plasma cell clone, but it can be a B cell clone. And we want to order a FISH because that may help us in decision-making down the road for those patients. And the last part that I will discuss is on prognosis in this disease. This is a slide I like to show because it well demonstrates the significance of cardiac involvement in this disease. So as I said, kidneys and the heart are the two major organs in this disease. Now let's look about the survival of patients that have those organs as a sole organ involved versus a multi-organ, and still start with the kidneys. So you see in the red curve what happens to the survival over time when the kidneys are the only one to be affected, and what happens to the survival, how greatly it drops the survival once there is more than just the kidneys. But for the heart, it really doesn't matter. Whether you have a single heart involvement or part of a multi-organ involvement, the survival is quite dismal, regardless of how many organs are being involved. This is how crucial the heart involvement, and unfortunately, it's quite prevalent in this disease, for survival. This is why we have the cardiac staging. This is a staging that is based on the cardiac biomarkers, the troponins and natriuretic peptides, to assign risk group and understand what the survival of those patients may look like moving forward. The first staging system was the 2004 Mayo staging system that was modified later on. This is solely based on cardiac biomarkers, the troponin T and NT-proBNP, and this is the cutoffs. And the modification is when they took stage 3, which has the 2 biomarkers above the threshold, and separate out in 3A and 3B using a higher threshold of NT-proBNP. The advantage of this cardiac staging system is that it singles out the patients with the worst prognosis, people that have really poor outcome, and most of them die within 6 months of their diagnosis. The other staging system is the Mayo 2012. This based again on troponin and NT-proBNP as the first system. This is a little bit different cutoffs, but also add to it the DFLC, which is the measurement of the involved light chain minus the uninvolved in the blood. And again, you get a 4 nicely separated out survival curves for those patients. So this is the cardiac staging. Now, those cardiac staging were developed using the troponin T and the NT-proBNP, but other centers use other cardiac biomarkers, and we have, for example, the high sensitivity troponin T that was introduced some 5 years ago. So we have this conversion tool with work from several centers that you can actually assign the cardiac stage almost with all the cardiac biomarkers available. So you can use that in order to assign the cardiac stage of the patient. The renal staging, it's a different staging system. It's based on the measurement of the organ, the severity of the organ damage. But as I've shown, renal involvement is less effective for survival, but we know that patients with renal involvement are more likely to go into dialysis. This is a very poor outcome for those patients, and this is the purpose of this renal staging, to estimate what is the risk of those patients going into dialysis moving forward. So for example, this is a 3-stage system. The stage 3 is when the proteinuria is more than 5 grams and the eGFR is less than 50. And you can see both in the testing and the validation cohort a good separation of the curves of the risk going into dialysis between those 3 stages. Now, we have other prognostic markers in AL amyloidosis. There are factors related to the organ involvement. We know patients with autonomic and liver involvement usually have a poorer survival. We know that there are factors related to the underlying plasma cell clone. The percentage of the bone marrow plasma cells can have an effect on survival. We know that the FISH genetics either have an impact on survival or on the response to therapy. So these are very important to obtain at baseline. And we also know that the response to therapy is quite crucial for survival, both the hematological and the organ response, and hopefully we can discuss it in the Q&A session. And now I have the question, right? So are you presenting it from this slide? Okay. So this is a question about diagnosing of AL amyloidosis, and I want you to please choose what do you think is true, what is the true statement here? A negative congruent staining on a bone marrow specimen rules out all types of amyloidosis. B, positive congruent staining on a bone marrow specimen confirms the diagnosis of AL amyloidosis. C, which I'm sorry that I haven't touched, a positive PYP scan confirms the diagnosis of cardiac AL amyloidosis without the need for further test. D, tandem mass spectrometry and a tissue biopsy is the best way to confirm diagnosis of amyloidosis light chain type. And E, in most cases, AL amyloidosis can only be diagnosed after biopsy of an organ suspected to be affected. Please vote. Wow, 88%. You're the right answer. Okay, that's good. Please take it into your clinic. My last slide will be, no. Yep, summary. So we discussed the importance of making an early diagnosis. What are the challenges that we are facing in reaching this early diagnosis? We discussed about new ways, hopefully will come in the next years, the AI-based approaches to make an early diagnosis. And by the way, this cardiac algorithm that I showed you, the AI, the ECG, it's available for clinical use at Mayo Clinic. There are no alerts, but clinicians can look and maybe get information from that and maybe move forward with early diagnosis using that tool. We discussed about securing the diagnosis with a tissue. You cannot make a clinical diagnosis of AL amyloidosis, and that there is really no need for organ biopsy for most patients, not all patients, but most patients. We discussed how crucial it is to make accurate typing in order to deliver a proper therapy, and we discussed both the cardiac and the renal staging, which measure the severity of the organ damage, but also being used as an outcome surrogates in this disease, and those are important staging systems for communication, understanding what the patient is like moving forward. Thank you very much for your attention.
Bring up the next slide because it's our next speaker, and introduce. One more. Perfect.
Okay. And now it's my pleasure to bring to the podium Giada Bianchi, and she will be talking about a frontline therapy for transplant-ineligible patients. Thank you.
Thank you, Dr. Mukhtar, for the introduction. Thank you, everybody, for being here. It's really nice to see this room rather full. So my name is Giada Bianchi. I'm an assistant professor at Harvard Medical School. I serve as associate director of the amyloid program at the Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. These are my disclosures. So I'm just going to repeat also a few concepts that Dr. Mukhtar discussed with you already, but this, I think, is really of the essence when we discuss AL amyloidosis. So what do we have to think about when we think about approaching a patient who's newly diagnosed with AL amyloid? So as you know, this is a two-stage disease. The first portion of the disease occurs in the bone marrow, where you have a malignancy, most typically a plasma cell disorder, that secrete a virulent protein. So an unstable immunoglobulin-free light chain. Based on chemical, physical characteristics, this protein tends to misfold once it's secreted outside the cells. Small protofibrils generate in circulation, and then eventually these protofibrils elongate, becoming insoluble and deposit in target organs. Here, depicted here, is a heart with the fibrils in green. So this is really the essence of the problem. We treat AL amyloid not because really of the plasma cell clone. In most of the cases, this would be considered an MGUS or a smoldering myeloma, but because of the organ damage that this fibril deposition bring about. The fibrils get interspersed in the normal cellular system of the target organs and disrupt the normal function of that specific organ. They also appear to be directly cytotoxic in their soluble form, entering the cells and disrupting the normal cell cycle and system in the cellular of interest. Now, you're faced with a problem here, right? So if you manage to normalize the free light chain rapidly and deeply, then the body is actually equipped with cleanup system. So cells of the immune system, we believe mostly macrophages, perhaps neutrophils, have the capability of phagocytosing these fibrils and remove them from the target organ, therefore bringing about reversibility of the damage. If the reduction of the free light chain is incomplete, insufficient, or late in the game, and the fibrils remain in the organ for a long time, we believe there is a fibrotic process that takes place trying to encasing and surrounding these fibrils will then bring about irreversible organ damage, which in the case of the heart is the major determinant of death in this disorder. So time is of the essence in AL amyloidosis. So if you were to ask me, so I ask myself the question, what is the ideal therapy for a patient with AL amyloidosis? I would say the one that can bring about the deepest response in the shortest time with minimum risk to our patients. So this slide I put together just to exemplify that when we approach a patient with AL amyloidosis, there are a few questions that we ask ourselves that are really critical to decide on therapeutic approaches. The first is whether or not a patient is eligible for clinical trials. Oftentimes, these clinical trials really provide an opportunity for patients to access drugs that we believe are highly successful and no cost. And so clinical trials should be offered to this patient, and of course, they help leading to FDA approval and understanding the disease better from a biological perspective. Next question is whether a patient is transplant eligible or not. This is a big ramification point, as really eligibility for autologous stem cell transplant remained, up until I want to say 5 or 10 years ago, the major determinant of long-term survival for these patients, because therapies in AL amyloidosis were really quite scarce. But as you see here, after this ramification, at least in our center, we tend to approach patients very similarly. So we give induction chemotherapy to everybody with Dara-CyBorD, and then for those patients that achieve a suboptimal response, where we think consolidation could bring about MRD-negative disease and portend longer remission, then an autologous stem cell transplant is offered in patients who are eligible. So as Dr. Mukhtar actually has already discussed with you, we have staging systems that heavily rely upon the extent of cardiac damage to determine the prognosis in this disease. And if you were to compare the original Mayo 2004 staging, where the stage 3 was not divided in 3A, 3B, versus the revised European staging system of the Mayo 2004 that includes the breakdown of 3A versus 3B, versus the most recent Mayo Clinic staging that encompassed the delta of free light chain, you'll see that the staging system that actually capture best the early mortality, so the one that occurs from about time of diagnosis to about 6 months, that's the Mayo European modified staging, where we have 3B, 3A staging system that capture that population that has impending risk of death because of cardiac events. Now, the staging system, as well as the pattern of involvement of organ, the severity of involvement of organ, and particularly the involvement of cardiovascular system at large, including refractory recalcitrance or orthostatic hypotension, they play into a role as we think about who is a transplant-eligible patient with AL amyloidosis. There has been a number of staging system or recommendation or guidelines for stratification regarding auto stem cell transplant eligibility that have come down from work led by the BU group, the Mayo Clinic, and the National Amyloidosis Center in the UK. We also put together with colleagues at Tufts our own criteria that we use to stratify patients for autologous stem cell transplant, but you see across all the staging system or criteria system, there are recurrent theme that reflects the clinical severity of this patient. This is important because when patients are not properly stratified for an auto stem cell transplant, the transplant-related mortality is high in patients that have advanced cardiac disease particularly. If you bring together all these considerations, we think roughly just about 20% of patients with AL amyloidosis would be candidate for an auto stem cell transplant at full dose melphalan 200 milligram meter square. So these lead us to talk about things other than auto stem cell transplant. And I pitched to you the question earlier than later. That's different what Eli has done. So my question for you is, like, if you think about daratumumab in AL amyloidosis, which one of the following is not true? Dara-CyBorD is FDA approved for cardiac stage 1 to 3A in AL amyloidosis. That's your option number A. Option number B, adding Dara to CyBorD improves hematological complete remission rate. C, adding Dara to CyBorD does not improve early survival in AL amyloidosis. D, Dara promotes macrophages-mediated amyloid clearance. And E, Dara may interfere with RBC cross-matching. So sorry, cast your vote. Do I have to do anything? No. Oh, I see. Excellent. So this gives us a bit of food for thought, okay? So we're going to discuss and actually touch upon all these points. So DARA-CyBorD has been FDA approved and also approved in Europe for the treatment of patients with AL amyloidosis stage 1 to 3A, based on a seminal study, the Andromeda study, a phase 3 randomized protocol that compares CyBorD, which was used as standard of care in amyloid off-label, versus DARA-CyBorD. You see that the DARA arm in the protocol really outperformed quite heavily the CyBorD arm in the protocol, both based on the percentage of overall hematologic response, with deep responses or satisfactory responses, meaning VGPR or better, of about 80% as compared to 49% for the CyBorD arm. These responses that were considered satisfactory in terms of preserving continuous organ dysfunction translated in organ response both at the level of the heart and the kidney that was significantly improved by adding DARA to CyBorD. So you see 42% cardiac responses versus 2% in the CyBorD arm, 54% renal responses versus 27% in the CyBorD arm. And then if we look at a novel way that we can assess really the depth of these of the disease response by measuring deep suppression of the involved immunoglobulin-free light chain to less than 20 milligram liter, or a difference between the involved and uninvolved free light chain of less than 10, you can see that the DARA group really achieved this goal quite successfully. About 60 to 70% of patients have very deep suppression of the circulating in immunoglobulin free light chain as compared to 20-30% of CyBorD alone. Does this matter in terms of how these patients do long term? The Andromeda protocol incorporated the major organ deterioration PFS as an endpoint of the protocol, which combined both the hematological progression-free survival with major dysfunction of crucial organ, namely heart and kidney. So any cause of death or achievement of end-stage renal or cardiac disease were incorporated in this curve. So as you can see here, the daratumumab arm, the patients in the daratumumab arm had a significantly improved outcome. However, I want to point out this area of this curve. So the 0 to 5 months from commencement of randomization, you see that the curves are basically overlapping to each other. So daratumumab really does not affect the early mortality that is brought about by irreversible end-stage organ damage at the level of the heart. Daratumumab was also good across the board regardless of staging. Actually, with the signal that patients with stage 3A appears to have a disproportionate benefit from adding daratumumab to their initial combination. And daratumumab was also able to overcome the negative prognostic factor of the translocation 11-14. So how about the 3B patients? These patients were excluded from this phase 3 protocol. We are starting to see a number of publications retrospectively looking at patients with 3B AL amyloid and the effect that DARA has on these patients. This is the experience of colleagues on the East Coast. This is the experience of colleagues in Europe. Using a daratumumab-containing regimen in patients newly diagnosed with AL amyloidosis induce very deep hematological remission here in the histograms with the red bar that translate also in cardiac responses with a significant decline in the NT-proBNP derived from use of this therapy. If you look at overall survival of patients stratified according to their treatment, you see that the patients who received DARA in the green curve had a significantly improved overall survival as compared to patients who receive a bortezomib-containing regimen or something else. The reason that I think this is all happening is because DARA is highly potent in inducing rapid reduction of the free light chain, of the circulating free light chain. And as I mentioned to you, the free light chain appears to be directly cytotoxic to the heart and obviously drives the formation of ongoing fibrillary deposit. This is work from Dr. Sancharawala and others of the phase 2 trial of DARA single agent in AL amyloidosis that depicts the decline in free light chain after one single dose, not one cycle, so single injection or infusion of DARA. In this patient, you see how the change in the free light chain is very powerful, and you can have normalization of free light chain. We have seen this happening over and over after one single dose of DARA. So what DARA doesn't do, brings us back to the question, DARA has no direct effect removing the fibrils from the target organ. So this is the one thing that the magic bullet DARA doesn't do. So this remains a large unmet medical need. As you recall, the early mortality is really driven by cardiac events. And so by irreversible cardiac damage and generally electromechanical dissociation and sudden cardiac death. So to attend to this major unmet clinical need, there has been significant research and development that have brought to our patients 3 distinct monoclonal antibody whose job is actually to bind to the amyloid fibrils and solicit those macrophages and other cells with phagocytic activity to come by and remove the amyloid from the target organs. We have 3 compounds currently in clinical development with birtamimab and anselamimab being both monoclonal antibody that recognize an epitope of the free light chain, both kappa and lambda, that is only exposed when the light chain is unstable and misfolded. So this epitope is actually hidden in a light chain that is properly folded. And therefore, only recognize the misfolded free light chain, kappa and lambda, as well as the fibrillary deposits derived from both kappa and lambda light chain. Both these antibodies are in advanced stage of development, a randomized phase 3 trial with anselamimab that has completed both trials for 3A and 3B patients, and the birtamimab study is currently ongoing. There is also a novel compound, the AT02, which is earlier in phase of development, is currently in phase 1, that actually use a completely different approach. And rather than recognizing an epitope that is expressed from the immunoglobulin light chain, it actually has an added portion, like a small peptide, at the immunoglobulin site of this antibody that then recognize hypersulfated glucosaminoglycans, which are a component of any sort of amyloid fibrils you are dealing with, whether this is AL, AA, or a TTR. The fibrils have incorporated within the structure these hypersulfated glycosaminoglycans. So this is considered a pan-amyloid targeting antibody, and we're eagerly waiting how the result pan out. So what do these antibodies do for our patients? These are data derived from the phase 1 clinical study of anselamimab that show in this histogram plot the decline in NT-proBNP of patients receiving this antibody as a single therapy. And you see that they tend to have very rapid and actually quite often about 60% of patients achieve a satisfactory cardiac response to this antibody, which then translated functionally in improvement in global longitudinal strain of the heart, which is a measure of how much the heart is impaired or stiffened by the presence of fibril within. These are overall survival curves that were just published, derived from a post-hoc analysis of the VITAL study. This was a phase 3 randomized study that focused on birtamimab use in stage 4 AL amyloidosis. The VITAL study was closed for futility. However, a post-hoc analysis and deeper assessment of the data showed that patients that had very advanced cardiac disease, so if you zone in only on the Mayo stage 4 patient, appears to derive benefit from the use of birtamimab in newly diagnosed AL amyloidosis. This was confirmed formally by this post-hoc analysis and provided the foundation for the AFFIRM-AL clinical study that is currently ongoing. So what next? If DARA-CyBorD fails our patients, or if patients relapse after the use of DARA-CyBorD, what is happening in amyloid therapies that target the plasma cell clone? So historically, we have continuously looked at multiple myeloma therapies with a lot of interest, as the cell that drives AL amyloidosis is very similar to the cell that drives multiple myeloma. Particularly, there is a lot of interest ongoing in targeting BCMA, which you all well know has become really a critical target for development of cellular immune therapies in multiple myeloma. I have outlined here in green therapies that are FDA approved in myeloma, in red therapies that are not FDA approved in myeloma. And so obviously there are a number of bispecific T-cell engagers that are either approved or in clinical trials in multiple myeloma, which we eagerly await to be challenged in the treatment of AL amyloidosis, as well as CAR T-cells, 2 different compounds that target BCMA. And then there are the new antigens on the rise, so GPRC5D and FcRH5 that are in clinical development in myeloma, with talquetamab already approved and cevostamab in advanced clinical studies that could be also target for the treatment of AL amyloidosis. And finally, BCL2. So venetoclax, as you know, has been really a revolutionary drug in a number of hematological malignancy, including translocation 11;14 multiple myeloma. As translocation 11;14 is the most common translocation in AL amyloidosis, present in about 50 to 60% of patients, there is a lot of interest in clinical trials validating the use of venetoclax in this patient population. So this is based on experience that most of us have had using venetoclax off-label or using venetoclax in patients who have both multiple myeloma and AL amyloidosis off-label, where you can see very rapid decline in the free light chain and very rapid responses that in this one particular case actually translated quickly in MRD negative status and organ response in a patient that had had multiple line of treatment and primary refractory disease. In this swim plot, you also see that these responses to venetoclax used in combination with dexamethasone or other plasma cell-directed therapy can be quite long-lasting, and patients can derive extended benefit from the use of venetoclax if they carry an 11;14 translocation. Now, this is a retrospective study looking at like about 40 patients with AL amyloidosis treated with venetoclax. And as you can see here, consistent with what we have seen in multiple myeloma, the presence of a translocation 11;14 is really critical to guide responses. You see here about 80% of VGPR or better in patients carrying an 11;14, and about less than 40% in patients that do not carry an 11;14. These translate in a significant improvement in PFS in patients with an 11;14 translocation, and also a signal for significant improvement in OS. Now, you notice, though, that the response in non-translocation 11;14 was not 0, and so there is more to it than just the 11;14 translocation, and there is considerable work going into identifying predictive factor of response to venetoclax in patients who have plasma cell disorders. How about BCMA? So belantamab mafodotin, the antibody drug targeting that binds to BCMA, has been tried again off-label in AL amyloidosis with significant success and really no signal for added toxicity with the exception of what had already been seen in myeloma. And then, as I was mentioning, there is interest in using BiTE therapy. This is a slide coming from PEN of the use of teclistamab in patients with AL amyloidosis, where you can see the patients achieve very rapid responses that can be quite long-lasting. I invite you to visit a poster abstract tomorrow that can provide more data regarding these. And of course, we're looking forward for clinical trials of BiTEs in AL amyloidosis. Finally, I want to close introducing CAR T-cells in AL amyloidosis. This is a clinical trial coming out from our colleagues in Israel with an academically developed BCMA targeting CAR T-cells that was specifically designed to be administered in both myeloma and AL amyloidosis. These data were reported already, and there is an oral abstract that will be presented on Sunday with more extended data regarding their experience in AL amyloidosis with this compound. As you can see, patients that were enrolled on this study were actually quite ill, including patients with 3A cardiac staging and advanced heart failure symptoms, including NIA class 4 symptomatology. The molecule triggered achievement of complete remission in all patients that were reported at that point, including MRD negative disease at 30 days, and importantly, evidence of cardiac response based on NT-proBNP and improvement in NIA class symptoms. CRS was frequent, and including grade 3 events, and the duration of response, I think, is where we need to remain focused and understand how much this patient can derive in terms of extended response to these therapies. And with that, we are at the key take-home points. So the prompt commencement of highly active antiplasma cell therapy is really critical for patient survival. And so Daracybord-D has become standard of care after its approval in stage 1 to 3A patients. And I want to say probably most of us use it routinely and with a lot of enthusiasm in 3B patients, understanding that normalization of free light chain is critical for organ preservation. Currently approved therapy do not target, so we do not have any therapy that targets directly the fibrillary deposits. This is something that we have molecules in the development, with some in advanced stage of development, that could provide that unmet need of early mortality. Clinical trials of antifibrillary antibodies are ongoing, and we look forward to more clinical trials validating other therapies, such as BCMA targeting agent, as well as BCL2 targeting therapy in this patient population. I have a busy slide with acknowledgements, and we're going to read each line all together. Okay? I'm kidding, okay? Stay with me, stay with me. So I just want to thank you, the Amyloid Program at the Brigham and Women and Dana-Farber Cancer Institute, all the clinicians, the nursing staff, the research team, and colleagues across all specialty that really provides outstanding care for our patients. All my team in the lab at the Brigham was doing a lot of work specifically in identifying novel targets for amyloid. My chief, Nancy Berliner, my team, clinical leadership team at the Farber, Paul Richardson, Jacob Lobach. Particularly, I want to thank you for bearing with me, Dr. Zonder for the kind invitation, Ms. Hood, because she has done an outstanding job bearing with us, providing slides, and primarily all the patients and their family who endure this disease with a lot of dignity and a lot of enthusiasm for paying back to future generation and all my funding agency. Thanks a lot. And now I have the pleasure also to introducing the next speaker, who's going to tell us everything we will ever wish we knew about TTR amyloid as hematologist. So Dr. Laura Obici from the Fondazione Policlinico San Matteo in Pavia, Italy.
So, good morning, everyone. And first, I wish to thank Professor Zonder for this kind invitation. It's really a great honor to participate in this symposium. So, in my presentation, I will try to briefly discuss some recent advancements in the management of transthyretin amyloidosis. And I will try also to highlight whether these new learnings in ATTR field may be relevant to hematologists dealing mostly with light chain amyloidosis. Sorry. These are my disclosures. So I want to start with the short clinical case because it's quite representative of a situation that we are increasingly facing in our clinical practice. So this is a 73-year-old male patient that was referred for suspected AL amyloidosis. In his past medical history, it's worth mentioning surgery for bilateral carpal tunnel syndrome, age 65, but also treatment for trigger finger and rotator cuff tear. He has a well-known IgG lambda M gas since the age of 58 years that was stable at hematological follow-ups. And a few months before referral, he started complaining of dyspnea on exertion, and he underwent a cardiological evaluations that showed changes in ECG that were not previously reported, and on echocardiography, increased mean left ventricular wall thickness with reduced ejection fraction, quite suggestive of cardiac amyloid infiltration. And also MRI was consistent with amyloid infiltration, showing mild subendocardial late gadolinium enhancement. The patient also underwent biphosphonate scintigraphy, and this examination didn't show cardiac uptake. So the patient was referred for suspected light chain amyloidosis. On presentation, his symptoms were weakness, moderate weight loss in the past year, dyspnea, orthostatic hypotension, and shoulder and knee pain. And on the right, you see the test results. The presence of the known IgG lambda gas was confirmed by serum immunofixation, no monoclonal light chains, normal free light chain ratio, and no significant renal abnormalities, and normal blood cell count, and normal electrolytes. He underwent a bone marrow biopsy showing an infiltration of plasma cell of 8%, and the biopsy was positive for amyloid. So the question now is, what would you do now for these patients? And we have 5 different options. A, demonstrate elevated NT-proBNP to confirm the diagnosis of cardiac light chain amyloidosis. B, no additional tests required. The patient has AL amyloidosis confirmed based on the positive bone marrow biopsy and the negative DPD scan. C, amyloid typing should be performed to confirm light chain amyloidosis. D, lack of family history excludes an hereditary amyloidosis, so no genetic test required. And finally, no additional tests required. Again, the diagnosis of AL is confirmed based on positive bone marrow biopsy, negative DPD scan, and absence of neurological symptoms. Please vote. Great results. Okay, that's very good. Yes, thanks a lot for. No, yes, this is the correct answer, of course, and this is really what we wanted to hear from the audience, and reflects your experience and knowledge in this field. That's good. We can go back to the presentation. Thanks. Okay, so. Actually, we did amyloid typing in these patients by immunoelectron microscopy, which is our gold standard in Pavia since many years, and actually these patients turned out to be affected by transthyretin amyloidosis. And genetic testing showed an heterozygous clearly pathogenic variant, which is phelan 78 based on the old nomenclature. The patients also had a mild sensory motor neuropathy when investigated by the neurologist, so in the end, he suffered from hereditary TTR amyloidosis with a mixed phenotype, and therefore a gene silencing therapy was started. So I included this case because we all are increasingly familiar with the diagnostic algorithm for cardiac amyloidosis, and some possible pitfalls may arise when we discuss diagnosis of light chain amyloidosis. In fact, the diagnostic algorithm is quite clear. Whenever you have a monoclonal protein, the diagnosis, as was discussed elegantly before, should always be performed on tissue biopsy after accurate typing. And a grade 0 is not specific nor suggestive of AL amyloidosis in itself. So basically, a DPD scintigraphy result is not significant irrespective of its grade when you have a monoclonal protein, because you always have to type the amyloid in tissue. But this case is important to recall that there are many different mutations in the TTR gene that actually do not have a positive DPD scan or PYP scans for reasons that are still not known. Even the most common Val30Met variant, which is observed in the Portuguese population, is not diagnosed even when overt heart involvement is present by DPD or PYP scan. So this is extremely important to recall. But certainly bone scintigraphy has dramatically changed our ability to identify and diagnose transthyretin amyloidosis. And non-invasive diagnosis is possible only for transthyretin amyloidosis when two conditions are satisfied: a positive bone scintigraphy with a grade 2 or 3, and complete absence of a monoclonal protein searched by serum immunofixation, urinary immunofixation, and free light chain ratio. So in this case, you can diagnose transthyretin amyloidosis, and the further step is TTR genotyping to discriminate between the most common wild-type transthyretin amyloidosis, which is typically a cardiac disease that affects males over the age of 70 years, and the variant TTR amyloidosis, which is a less frequent disease but much more aggressive and is typically associated with more systemic manifestations. And this is extremely important to discriminate between the two types, because for variant ATTR we have different treatment options, as I will discuss, and the information is also quite relevant for cascade genetic testing in at-risk relatives. We are increasingly recommending that even males over the age of 75 or 80 are genetic testing, even if the clinical picture and the results are completely consistent with wild-type TTR amyloidosis, because the proportion of cases of hereditary isolated cardiac TTR in late ages is up to 10-20%. So it's important not to miss also this patient's population. So what do we know about the structure and the function of transthyretin? Transthyretin is a transport protein, and its best characterized functions are the co-transport of vitamin A through retinol-binding protein and the transport of thyroxine, particularly in the CSF. The circulating TTR is produced primarily by the liver, whereas the choroid plexus of the brain secrete TTR in the CSF. The native structure of the protein is shown in this picture. This is a homotetrameric protein consisting therefore of 4 identical subunits, and it's important to remember that at the interface of 2 dimers there are 2 tiny symmetrical channels. These are the thyroxine binding channels for TTR, and binding to tyrosine increases the stability of the native structure of the protein. How essential is TTR in human beings is not well characterized. There is no report of complete lack of TTR in humans, and also the protein is highly conserved through a vertebrate evolution. There is a high similarity in the native structure of TTR between vertebrate fish and humans. But on the other side, it's important to remember that the large majority of the protein actually circulates unbound, because thyroxine is mostly bound to thyroxine-binding globulin and to albumin. So whether the native structure of the protein is key for the physiological functions of TTR, we know that dissociation of the tetramer due to destabilization of the protein is the key rate-limiting event in TTR fibrillogenesis. And there is increasing investigations about what is priming dissociation of TTR under physiological conditions. And in recent years, it has been clearly and elegantly demonstrated both by in vitro and in vivo studies that this process is primed by the sequential action of biomechanical forces that expose protease-sensitive loops in the protein and proteolytic remodeling, releasing truncated C-terminal monomeric species that are highly amyloidogenic, much more amyloidogenic than the full-length monomer. We know that proteolysis is quite relevant also in light chain amyloidosis. Here in TTR amyloidogenesis is becoming increasingly relevant because of its highly specific target, because the fragments are quite homogeneous and all start at residue 49, suggesting a specific enzyme playing this role in vivo. And there is increasing studies that show that this enzyme can be plasmin. Plasmin has been shown also in an animal model of TTR amyloidogenesis that is key for deposition of the protein in the heart. And when these mice that overexpress a highly aggressive mutant are knocked out for alpha-2 antiplasmin, which is a natural inhibitor of plasmin, the amount of amyloid that the mouse develop is extremely high. So this is quite relevant. It's not yet a target for therapeutic purposes, but may become in the future. Presently, however, our increasing understanding of the fibrillogenesis process for TTR has led to the development of effective therapeutic options that target different steps of the cascade. So, similarly to light chain amyloidosis, we have a class of drugs that suppress the synthesis of the amyloidogenic precursor. And these drugs that knock down both the mutant and the variant TTR are both RNA interference agents like patisiran and vutrisiran and antisense oligonucleotides like inotersen and eplontersen. Both classes exploit endogenous mechanisms for mRNA degradation. So complete degradation of protein mRNA results in absence of synthesis and suppression of circulating concentration. Interesting, there is a new approach to knockdown of circulating mutant and variant TTR, which is under investigation, that exploits the CRISPR-Cas9 technology, therefore providing irreversible gene editing of TTR gene in the hepatocyte. And I will tell you something more later on. The second class of approaches that we have for the treatment of transthyretin amyloidosis is represented by TTR stabilizers. TTR stabilizers are small molecules that selectively bind in the thyroxine binding channels of this tetrameric protein and increase the stability of the tetramer, preventing dissociation, misfolding, and aggregation. Then a third approach that is similar to what has been discussed for light chain amyloidosis is immunotherapy, exploiting anti-TTR antibodies that recognize epitopes that are only expressed on misfolded TTR or on TTR amyloid fibrils. So, as I said, tafamidis is the first in class and presently the only approved TTR stabilizers for transthyretin amyloidosis. It has been approved both for the treatment of polyneuropathy in hereditary TTR patients and for cardiomyopathy, both wild type and hereditary. And this is based on the successful results on the ATTRACT trial. In this trial, it was clearly demonstrated that treatment with tafamidis increase survival and reduce cardiovascular-related hospitalizations. And also the data from the long-term extension study confirm the beneficial effect of patients on tafamidis over more than 5 years compared to patients that were previously on placebo, highlighting the need for early treatment to get the maximum benefit from this approach. And again, even more recent investigations, retrospective investigation in this patient's population confirm the beneficial effect across the different classes, but of course the benefit is higher for patients that start the treatment in NIHY class 1 and 2. Tafamidis is an effective drug in slowing progression of the disease, but its ability to completely stabilize the disease is observed only in a subgroup of patients. And this is particularly true for patients with hereditary TTR, probably because mutations increase the destabilization of the tetramer and therefore reduce the efficacy of the approach. That's why gene silencing agents have been developed and were shown to be particularly effective in this setting. These, as an example, are the results of the long-term exposure of patients with hereditary TTR with polyneuropathy to patisiran. Patisiran is the first RNA interference approved for transthyretin amyloidosis, but also the first RNA interference drug ever approved for any indication, and it has paved the way to the development of this strategy for other rare diseases. And these results are extremely important, and for us dealing with this disease were really amazing when we initially observed the difference after the 12 months of the Apollo registrative studies between the treated patients and the placebo arm in terms of neurological progression. The drug is able to completely stabilize neurological progression over years. These are the longer follow-up available, and the disease remains completely stable, as well as the quality of life is preserved in these patients over so many years. Again, the difference between the patients when the treatment is started early or the treatment is started after a placebo period is striking and remains over time, highlighting the importance of early treatment. And recently we are also looking for novel endpoints. The trial, as well as the trial with enotersen, was quite good for developing new endpoints for this disease, particularly for neurological disease. And this is quite relevant also in the future for light chain amyloidosis, because the new treatment that were discussed before are certainly in search of new endpoints that are independent from the hematological response. And in the bottom, you see the response of neurofilament light chain, which is a novel biomarker for neuropathy. It's not specific for transthyretin neuropathy, but it's quite sensitive and specific and useful for tracking response also in this condition. There are new generation gene silencers in this disease. These are advancements of the platform for the chemical modifications of RNA interference and antisense oligonucleotides. And binding to these 6 residues, GalNAc conjugates, allows for subcutaneous injection and lower doses and particularly longer intervals between administrations. So presently, patients are treated with vutrisiran every 3 months, with significant suppression of TTR similar to patisiran and substantial beneficial effect on neuropathy progression. And very recently, also the data of the new antisense oligonucleotide eplontersen were published. Again, there is significant suppression of the TTR precursor, as you see in the bottom here. And this translates with significant neurological benefit over only 66 weeks. Patisiran has been also investigated in TTR cardiomyopathy, both wild-type and hereditary TTR cardiomyopathy, and the results of the Apollo B trial were recently published in the New England Journal. And the drug met the primary endpoint, that is the change from baseline in 6-minute walk test, and also secondary endpoints of quality of life related to cardiac disease and change in NT-proBNP. But the secondary composite endpoint of death from any cause, cardiovascular events, and 6-minute walking test was not significant. And this was substantially related to the short duration of the trial, because actually the trial was only 12 months long. So in spite of the power effect of the drug in changing the natural history of the disease over such a short period, the lack of more robust cardiac endpoints according to the FDA was not considered not sufficient for approval of the drug. So again, we are learning a lot from clinical trial for cardiac indications in TTR amyloidosis in terms of optimal endpoints for cardiac disease. I want to spend a few words on preliminary results from the experience with the NTLA 2001, which is a CRISPR-Cas9 in vivo gene editing drug that is under investigation in a phase 1 study in patients with ATTR cardiomyopathy and ATTR polyneuropathy in hereditary disease. And certainly based on the positive experience with gene silencing that can be provided to patients and suppress TTR for long periods in the absence of any safety signal, we moved forward with higher suppression with gene editing. And more importantly, gene editing is an irreversible approach to suppression of TTR because it's a once-in-a-while injection that completely edited the gene and results in a robust and persistent suppression of TTR concentration. And as you can see here, after only 4 weeks, the concentration of TTR is reduced up to 91%, both in patients with cardiomyopathy and patients with polyneuropathy, and remains substantially unchanged over long periods. So we are waiting for additional results and phase 3 trial. A phase 3 trial is starting now in patients with TTR cardiomyopathy to see how this additional reduction in TTR concentration translate in terms of organ response. And then before concluding, I wish to address immunotherapy in transthyretin amyloidosis. This study was only recently published and is quite encouraging in terms of the ability of these antibodies to remove amyloid fibrils formed from TTR by TTR in the heart. And in TTR amyloidosis, we have the possibility to track changes by bone scintigraphy as well as by cardiac magnetic resonance. And interesting, only after 4 and then confirmed at 12 months of treatment with this antibody that recognize epitopes that are only expressed on the amyloid fibrils, there was significant removal of amyloid deposition based on these indirect evidences. And this also translated in improvement in NT-proBNP. So is quite rewarding and suggests that this strategy can be exploited in systemic amyloidosis as well. I'm not entering any more what Giada has already brilliantly discussed about immunotherapy of light chain amyloidosis, where you have also important preliminary data supporting the beneficial effect of immunotherapy in light chain amyloidosis. I just want to provocatively discuss whether light chain stabilizers may also play a role as are TTR stabilizers in transthyretin amyloidosis in AL amyloidosis. This is much more difficult because of the heterogeneity of light chains and the difficulty to find conserved residues that can be able to bind a stabilizer and prevent misfolding and dissociation. But Jeff Gelly group, the same group that developed tafamidis for transthyretin amyloidosis, is attempting by a strategy to design drugs that are able to bind to constant regions identified on full-length light chains in order to form dimers that prevent this light chain from misfolding and aggregation. There are some possible candidates. There is no clinical trial ongoing yet, but maybe this could become in the future a complementary option also for patients with light chain amyloidosis in combination with antiplasma cell treatment. So to conclude, similarly to AL amyloidosis, systemic TTR amyloidosis is becoming a curable disease, although it remains extremely challenging for patients with delayed diagnosis. Available treatment aim at slowing progression or stabilizing the disease through suppression of the circulating protein or stabilization of the tetramer, and immunotherapy is becoming a reality in systemic amyloidosis, as we have seen both in AL and ATTR. Of course, we now need to have more studies to investigate the synergic role of these drugs among each other in order to improve cardiac function, prolong survival, and preserve quality of life. Thank you very much for your attention, and I also wish to thank all the colleagues from the Pavia Amyloidosis Centers, particularly Giampaolo Merlini, who is my mentor, and Giovanni Palladini, who now is the director. Thank you very much indeed. Thank you very much. It's now my great pleasure to introduce Dr. Rafat Abenauer, who is the director of the Myeloma, Waldenstrom, and Amyloidosis program in Indiana University. Thank you.
All right. Good afternoon. It's a pleasure to be here to talk to you about thrombotic and bleeding complication of amyloidosis. I need to send a shout out to the late Merrill Benson, who was an active amyloidosis researcher and physician at Indiana University, and always taught me that liver bleeds, and I will never forget that. 28 years ago, we had a patient who had a liver biopsy and bled about 6 units of blood. So I respect bleeding, diathesis, and amyloidosis. I have nothing to disclose, but a disclaimer that I am not a thrombotic expert or a bleeding expert. I just see a few amyloid patients a week, and Jeff asked me, so I couldn't say no to Jeff to present this. So the question is, why do patients with amyloidosis bleed? And why do patients with amyloidosis clots, and how to manage these patients. So we're gonna have a quick journey here to try to discuss these things. Just a reminder that the blood has to stay in the circulation, and several components of the bleeding of the vascular system and the coagulation system have to work perfectly. You have to have an intact wall, active platelet, but not too active. You have to have the balance between coagulant and anticoagulant proteins, and you have to have a fibrolytic system that work when you get a clot. And all of these things can be affected in patients with amyloidosis. So the way I'm going to present this, two cases. The first one is a 58-year-old woman with AL amyloidosis presented with biatrial thrombosis while in sinus rhythm. The prior symptoms that led to the diagnosis were orthopnea, postural hypotension, epigastric pain, anorexia, nausea, vomiting. You heard all of these different sort of symptoms that can be difficult to lead to diagnosis of amyloidosis right away, like you heard from Dr. Mokhtar. Finally, because of the anemia, I think they were doing a gastric mucosal biopsy and an upper endoscopy. Amyloidosis was diagnosed and confirmed by mass spectrometry, just to make you happy, Dr. Mokhtar. So an echocardiogram was done, and the ejection fraction was 45%. The intraventricular septum was slightly enlarged, 12 millimeter, but a 32 by 17 millimeter mobile thrombus protruding from the left atria appendage was seen. There was some thickening in the cardiac valves and the atrial septums. And the atria were moderately dilated. And they saw some hepatic vein dilatation and some pleural effusion. So the question is, why do patients with amyloidosis have thrombosis? And you can see that the first three things is really related to the heart. Having a cardiac involvement is very important, from heart failure to atrial fibrillation to really newly kind of described entity that we have sort of appreciated is atrial myopathy. And I think that's very important to keep in the back of our mind. Obviously, the other two things is that nephrotic syndrome. We'll talk about that in a little detail. And I was talking to one of my colleagues here, Dr. Burrell, about the use of immunomodulatory drugs, and they're very effective, but they can increase the risk of thrombosis. This is a work that done by Nicole et al. To sort of summarize some of the publications on thrombotic event in the patient with amyloidosis. And these are several studies that have been published in the last 20 years. Some of them are old, as the one by Fang in 2007, and where showed the incidence was about 33%. But a lot of these thrombotic events were actually discovered on autopsy. But if you look at Capilio et al. In 2020, they showed the prevalence is about 7.6%, and they identify a risk factor to be atrial fibrillations, lower ejection fractions below 50, chest to VASC score above 2, and chronic kidney disease. Dr. Matarini and colleagues reported on 290 patients with TTR. Their incidence was 6%. So you can see that quite variations in terms of the incidence and the risk for thrombotic event. So nephrotic syndrome, you're all familiar when you have more proteinuria, more than 3.5 grams per day, and you have a lower albumin of 3 grams. It does increase the risk of both deep venous thrombosis, renal vein thrombosis, and pulmonary embolus that can be asymptomatic in most of the cases. But it's very important to remember that it rarely can cause cerebral vein thrombosis or atrial thrombosis. So why does nephrotic syndrome do that? Why do patients do clot? Because there is a reduction in the level of antithrombin 3, protein C, and protein S, and there's increased level of fibrinogen, clotting factor, and so leading to sort of imbalance of the clotting factors. And more importantly, there is also damage to the vascular endothelial layers, glycoglycic. So that damage lead to platelet aggregations and clotting. Obviously, we all familiar that patient with nephrotic syndrome will present with hyperlipidemia, their cholesterol running in the 600 and similar. So the question, does that lead to inflammations and further activation of clotting factors and increase the risk of thrombosis? And I think there's a provocative question whether treating the hyperlipidemia is very helpful in reducing the thrombotic events, and I'm sure we all have different opinion on that. Personally, I believe that getting rid of the amyloid and correcting the nephrotic syndrome, which can occur quickly, luckily is one of the organs that improve the fastest, may lead to correction of the hyperlipidemia. So how do immunomodulatory drugs cause thrombosis? It's not really well understood. So patient underlying health factors may play a role, but they can also increase the risk of production and activity of platelet, can increase the production of certain procoagulant factors, and does interfere with the blood vessels. And we all know about the Virchow triad. That's very important to have an intact blood vessels and hemodynamic stability. So basically, thrombotic event in systemic amyloidosis, mostly atrial thrombosis and CVA, which can be more common actually in ATTR than AL amyloidosis. And again, what lead to thrombotic event is both the atrial fibrillations and atrial dysfunction. And one of the things that really near my heart is that, I believe that sometimes our colleague in cardiology and the nephrologists are very eager to try to get rid of every possible peripheral edema, which is impossible when you have somebody with low albumin. So using diuretics aggressively will lead to, sort of stasis, and stasis and reduced turbulence will lead to thrombosis. So I think being too eager, to over-diurese these patients may increase the risk of thrombotic events. There are some studies published on basically the prevalence of embolic events in atrial fibrillation, and obviously we know that's a risk factor, but you can use the CHA2 VAS score system, and the higher the score, the more likely you're going to see a thrombotic event, up to 11.1% in patients who score 5 or higher. Now the question is, how about the patients who are not on anticoagulation and in normal sinus rhythm? Is there a way for us to predict who's going to develop thrombosis? And actually, really doesn't. If you look at the patient in normal sinus rhythm, the higher the score, still maybe slightly elevated, about 3-4%, but it cannot predict compared to patient with atrial fibrillation. So you can't use that scoring system to help you. But I think we need to remember that patient with cardiac involvement, even without atrial fibrillations, are at measurable risk of getting a clot. So we should be sort of thinking about using anticoagulation in that setting, or obviously looking first closely to make sure that they don't have a clot by appropriate studies, beyond just the simple echocardiogram. All right, so let's move on to the other extreme of the we see in patient with amyloidosis. This is a 69-year-old male with basically restrictive cardiomyopathy, had an increased creatinine. They thought about amyloid, had a fat pad biopsy, and it was Congo red positive, and on physical exam had the loud S4, mild hepatomegaly, and this purpura. So the question is for you, and I think what is the reason for these patients to have this purpura? Is it severe thrombocytopenia, acquired factor inhibitor, absorption of clotting factor on amyloid deposit, acquired Van Willebrand factor deficiency, or cryoglobulinemia? Please vote. Do I need to push or? So I don't know if we have a voting. Okay. Did you get? Okay, here we go. Excellent. Excellent. So it seems the majority got the right answer. All right. So let's go forward here to the next slide. All right. Yeah. Are we? I think we're good. All right. So additional laboratory data obtained that had an elevated lambda light chain with an abnormal ratio. There was 8% lambda light chain restricted plasma cells in the bone marrow, mild anemia, and the patient had a prolongation of prothrombin time at 17 seconds and had a very low factor 10 activity of 7%. So what caused a patient with amyloidosis to bleed? A lot of different things. One of them is gastrointestinal involvement by amyloidosis. as we saw in this case, factor 10 deficiency, but also our colleagues in Boston have reported on several cases of other factor deficiency, including rarely van Willebrand factor. And there's obviously the concern about renal failure leading to platelet dysfunction. And not to forget that our patient with amyloidosis do present, some of them, with autonomic dysfunction, and they are at risk of falling and bleeding because of that. In AL amyloidosis, bleeding is more common than thrombotics, and actually bleeding is more common in AL amyloidosis than TTR. So this is a study that tried to evaluate 337 patients with abnormal bleeding and saw that 28% have abnormal bleeding and 51% did have an abnormal coagulation test. The most common site of bleeding were cutaneous in 18%, GI in 5%. Some of the tests that were abnormal, thrombin time, prothrombin time, and PTT, as you can see, 32 to 14%. Subnormal factor 10 levels are seen in about 14% of the patients. And it's not inhibitions, it's really absorption of factor 10 by amyloid. Thrombocytopenia was not common, about 3%. And again, as I mentioned here earlier, acquired van Willebrand factor deficiency was observed in rare cases. Basically, when we're dealing with factor 10 deficiency, how do we manage that? I think the most important thing is that the factor level matter, and so we should target for a level above 20%. For minor procedure, actually, tranexamic acid or epsilon aminocarboic acid are adequate. But for a major procedure, we should consider prothrombin complex concentrate, factor 10 concentrate when available, and fresh frozen plasma. If you have a very refractory patient who is bleeding, there have been some report, because where is the amyloid mostly deposited? In the spleen and the liver, and that's where you're absorbing a lot of factor 10. So theoretically, splenectomy may help, but I think maybe that's a little too aggressive. But in very refractory cases, you may need to do that. So my conclusion is that both bleeding and thrombosis are important complications of both AL and ATTR amyloidosis. We need to be vigilant about recognizing these issues and appropriate prophylaxis and measures and needed to, especially before procedure, to reduce these complications and improve the outcome. I think one of the most important things is really we need further investigation to understand the mechanism of these complications. And with that, I turn it back to the chair for moderation. Thank you.
Okay. Okay, perfect. First, I want to thank all of the speakers for excellent talks. We got a lot of questions online. Some of them I sort of earmarked, and you can see them on the app, but there are probably 10 times that many that have come through. We're not going to be able to get to every question, but I do want to focus on certain topics during the question and answer period that were sort of touched on repetitively in the by people who submitted questions. The first one has to do with management of stage 3B, or I suppose revised Mayo stage 4 cardiac patients, the ones who Dara-Cyborg isn't approved for because they were excluded from Andromeda. What are people's preferred regimens regimen for those patients when initiating therapy Dr. Bianchi, probably we should start with you since this was part of your talk, but I'd be curious to know what the other clinicians do in their own practice regarding this patient subset.
Yep, thank you. That's a great question. Thank you, Dr. Zonder. So I think I alluded to during my talk that I am one of those physicians who would recommend Dara-Cyborg-D in patients with 3B amyloid, despite the fact that there is no FDA label attached to it. Understanding that I think there are a critical population that is in particular acute need of normalization of free light chain as soon as possible. And therefore, I really feel that adding DARA in this patient population is critical to try to offset the risk of ongoing progression in the setting of ongoing amyloid deposition. Open to my colleagues.
Yeah, we are trying to do the same, basically, and otherwise to adapt the regimens for frail patients, including Cyborg or MDEX without DARA.
Okay. Ellie, the question I'll ask is, so in a patient with advanced cardiac involvement in whom you might pick and choose agents, cytogenetics, does it factor into decision-making about what one might pick or choose, as their initial therapy? It's a hard question.
I would say this. I mean, I think Dr. Bianchi well presented that you want to have effective therapy that will do it rapidly, that will be the less toxic. And we know that, Velcade might have some cardiac toxicity. It's been kind of touched in the amyloid space, but not too much. We know that, for example, carfilzomib, which is a more potent PI, has a more cardiac toxicity. So there is a potential damage for patients with already established great damage in the heart, given them the Velcade. But on the other end, you want to get the light chains, so it's kind of a balance that you don't know what to do with that. What I would say is that this is probably more applicable to the US because it's more easy to obtain drugs. If a patient does not have a good response to therapy, and I move to the second line, and if which is sometimes it's a hard choice because you need to have a good second line, and sometimes you don't have, especially patients with severe heart. But half of the patients have translocation 11-14. I go even beyond that. If the patient does not have 11-14 and has enough bone marrow plasma cells, I ask the pathologist to stain for BCL2. Because if the BCL2 is highly expressed, there is a good potential that venetoclax will work on those patients. And I think this medication is quite active. Actually, it's the best active agent as a single agent, I think, in amyloid. I mean, responses that are seen are just amazing. It's not cardiac toxic at all. So if we can move to this agent, not seeing a response that you want to see with the Dara-Cyborg-D, unfortunately, there are patients that are not responding or not responding well to the Dara-Cyborg-D. And, we need to get at least a VGPR. So if a patient has a light chain DFLC of 5, this is not a VGPR. I mean, and it's probably after 3 or 4 cycles, if this is where the patient is stuck, he won't get better. So it's unfortunate, and this is something that's difficult to convince physicians out there, that this is a response, it's just not good enough. And if there are alternatives, and I hope that other countries will have those availabilities, then move to the next agent, because you really need to get the light chains down in order to help the patient short run and long run.
Agree. I think continuing to work towards identifying patients beyond the 11-14 subset who might respond to BCL2 targeting is important. There is some work in myeloma from our colleagues at Emory, looking at a B-cell-like gene expression profile or surface marker profile that might predict response to venetoclax-based therapy, which might be applicable to our amyloid patients. I also do want to highlight, just while we're on this topic, there is an abstract on the Aquarius study, which is looking at this exact question of sequencing starting Cyborg-D and daratumumab simultaneously versus a staggered approach to look at safety. And that same study also has a minority patient cohort built into it specifically, which I think is going to be really relevant. There was an abstract from the Medical College of Wisconsin that is a poster, which was a retrospective analysis of amyloidosis patients based on socioeconomic status and looking at whether or not that had an impact on outcomes. When you think maybe it could, right? That patients in poor socioeconomic categories might have less access to regular, routine, medical screening and observation, less access to testing, and then maybe less resources to manage complications. It turns out they did not see a definite relationship between socioeconomic status itself and outcomes, but they, I think, showed the predictable association between race and socioeconomic status in the United States, and that there was an increased mortality for patients who were Black, even though it wasn't linked to their socioeconomic status. And so that's something that we really, I think, studies like Aquarius are going to be really important to sort of start sorting this out a bit, right? You touched on something that just came up about patients who start with low light chains. We got numerous questions about that. I think 5 different people sort of asked about this. Referrals regarding patients who are suspected to have amyloid based on the presence of congestive heart failure or unexplained neuropathy, and their light chains are minimally elevated, and maybe the ratios aren't even abnormal, technically. They're still in the normal range, but elevated. And this prompts a referral. So I think there's 2 parts to it, right? There's the scenario of getting a patient at that moment, where the question is, does this patient have amyloid? Do we need to do additional testing? That's one. The second one is, if you establish that that patient has AL amyloidosis, how do you follow that patient if the response criteria that we're used to using don't readily apply because their numbers are starting so low? So I don't know who would like to tackle that.
Yeah, I'd be happy to take this one. So I think there are a couple considerations here. Given the vast predominance of light chain lambda amyloid as compared to kappa, so 3/4 of patients are lambda, any kappa lambda ratio that is less than 1 that suggests that there is excess of lambda light chain in somebody who has compromised renal function, so a GFR that is not normal, should always be taken in consideration as an abnormal ratio. So in this patient, because of the kinetics of kappa versus lambda excretion in the kidney versus reticuloendothelial system, a physiologic ratio should be well above 1, generally above 2. And so patient with kappa lambda ratio of 0.5, I think that was actually your patient, Laura, that's a pathologic until proven otherwise. So that's one thing. The second thing is that we are happy to see, and I'm sure I'll speak on behalf of everybody, rather than not, patients who may have a ratio of 2, 2.5, 2.75, heart failure, nephrotic syndrome. We're happy to see them and then make decision based on a full assessment by hematology, whether or not further workup should be done. The risk of a skin biopsy or a fat aspirate of the skin is exceedingly modest and can be very informative, and so that's certainly something that we considered. As far as how we monitor these patients, I think in patients that have lambda disease, I usually use the criteria of looking for a reversal of the ratio. So even you cannot use the clinical, the approved parameter for monitoring response, a patient with lambda disease who is in a deep remission should flip the ratio from less than 1 to above 1. So that gives you an idea that they're responding well. And then I think we're working towards identifying criteria that just involve the absolute level of the light chain that is involved, or this delta less than 20 that may capture better patients who have this low level of elevation in the light chain. I also give you a bonus answer that you haven't asked me, but I'll ask myself the question and then provide an answer. So I think often of these patients because technically they're not considered high risk, right? The 2012 staging would not consider these patients as high risk because the delta of light chain is not above 180 milligram per liter. However, in my practice specifically, they have posed a challenge in the sense that they're often recalcitrant to respond very rapidly to therapy. And this may have something to do with the effort of protein synthesis and secretion that these cells make on a per cell base, where you may have very little immunoglobulin produced on a per cell base. And some of our therapies, particularly proteasome inhibitors, rely on that secretion process for their activity. So they have a prototypic low-risk disease. However, in my experience, they have a slower response to our therapy as compared to patients that may have very high burden of disease. Just curious to see, maybe Dr. Abelnour, do you have anything else or any other thoughts?
No, I mean, I agree with you, but I think the question is, does a low level mean that you have to stay aggressive with the patient treatment, or is it time to back off? Because, I mean, I think for years, we treated patients with just high-dose chemotherapy, and they're 20 years now still without any problem. So the question is it a balance between sort of production and the ability of the body to eliminate any, amyloid depositions? And I think that's an area that I still don't understand. I would love to see more research on that.
Can I add one more thing?
Please.
Patients come not because they have elevated light chain, they come because they have organ problems. So this is another mode of monitoring the response. So it depends on the presentation, but sometimes patients, we have some criteria for organ responses. Not all organs are, have some biomarker that we can measure, but we can look at the function of the patient. I have a patient with very low DFLC diagnosis. I cannot assess his response. But year into his therapy, it took him probably 6 months to get into that stage, he's less orthostatic, he's gaining weight, he's doing better, he feels better, he doesn't come with his brother any longer. I know that he's responding to therapy. Now, we have other issues to solve, but we know that this is another, something that you can use in the clinic to assess if he's responding or not, to see what happens to his organ response. Is he getting better or not?
We have a live audience question. Yep.
Hey, I'm Jason Chandler from Memphis. Would you ever use clonoSEQ to do MRD testing in that situation to see if you could get them negative?
Yeah, absolutely. I think it's a good approach to monitor patients on the basis of bone marrow infiltration, also to type and to prove the imbalance between the two different types of plasma cells and to monitor patients according to that. That was done since many years, and in some few cases it's the only way to confirm the clonality of the protein below. I just wanted to add a comment with respect to the case I presented. Actually, MGUS are quite common in the same age range of wild-type TTR amyloidosis. So as hematologists, you will find a significant proportion of patients in which ATTR coexist with the monoclonal gammopathy. It's true that more often these patients do not have unbalanced free light chain ratio, but this is not a criteria to exclude and consider them as wild-type TTR.
And to add to that, the demographics of the most common variant ATTR in the United States, right, the Val-122 isoleucine, right, that's also the much more common in African American patients and in older patients is when it tends to present later clinically. And so there is a huge overlap, epidemiologically, in terms of the patient groups who are, likely to be diagnosed with variant ATTR amyloid in the United States, and also light chain, plasma cell disorders in the United States. So we definitely see a lot of patients, presenting just like the case you presented. I mean, really a common scenario.
And the other point that was not discussed is the coexistence of different type of amyloid deposits, because we have increasing evidence, thanks also to novel approaches for typing of amyloid deposits, that there are patients in which co-deposition can occur either in the same tissue or in different organs. So again, it's extremely important to type to get the final answer.
So that actually is a question that came up in the thread here, which is, so if you have a patient with mass spec proven light chain in their marrow or a fat pad aspirate, and cardiac involvement by amyloid clinically, or by echocardiogram or MRI. But because a lot of patients, if we already know the light chain identity, right, they often will not get a PYP scan, that, in practice. And so the question is, so in an older patient with being treated for light chain amyloid who's having a hematologic response but seems to be having cardiac deterioration, how important is it to go back to the well and actually reevaluate whether the heart is involved by AL?
Yeah, that's a good point. Actually, I think in these patients in which you have a positive PYP and evidence of light chain amyloidosis on a different biopsy, we usually perform also heart biopsy to finally demonstrate that amyloid deposition is related to light chain or TTR or possible coexistence, because actually then you have to interpret treatment response, and you also have to define whether the patient deserves a treatment for cardiac TTR amyloidosis or not. Then there might be restrictions in some countries based on the coexistence of different types of amyloidosis, but I think the most important message is that you have evidence of organ disease and you are able to track response to treatment. So providing typing of the damaged tissue is important in this case.
Yep. We have another audience question.
Hi there. Quick question. What kind of NT-proBNP cutoff do you use to establish whether patients are safe to proceed to transplant? And if they don't meet that goal, how do you eventually de-escalate their therapy if, let's say, all the biomarkers and hematologic response looks adequate?
Yeah, it's a good question that we might have some data. So basically, centers exclude patients on basis of different criteria. One of the criteria that has been used was troponin, but also NT-proBNP at a cutoff of 5,000, which many will prohibit patients to progress to stem cell transplant. And I think that in today's, in time that we have more treatment, that's probably will be justifiable because this is quite elevated NT-proBNP. We are in the works of getting a model to predict transplant-related mortality. We haven't tried to identify a cutoff, so we use what has been available in the literature, and definitely NT-proBNP about the 1800 cutoff is a risk factor for death, but it's only one of the risk factors, so we'll see how it goes with that. If I don't have any other options, and that's the only parameter that is kind of an abnormal, then it's a frank discussion with the patient. We don't have any other options. You might be a good, I don't have to call it a good, but we can consider you for transplant. There is an increased risk. The risk is around 2% if that's the only marker that is present for transplant-related mortality. And if the patient is willing to take the risk and you're willing to take the risk, then I think this is something that need to be discussed. Obviously, when you exhausted all treatment options, and actually, we have now teclistamab maybe, and anti-BCMA, and we have the venetoclax, so, that decision might be pushed away. For the reduction of the NT-proBNP, it really depends on many factors. Is the patient, for example, on IMiDs, because that will drive the NT-proBNP. Maybe if you pull that off, maybe that will improve the NT-proBNP. A good cardiac care can do that. Diet, that the patient don't eat pickle every day, this happens, by the way. So it's kind of, it's a very broad question. But sometimes pulling off treatment might actually help patients rather than, especially if they are in a good response. And give them a treatment break may actually improve their heart function because treatment is a load on the heart.
Yeah, I just want to echo that and just add, a couple of things. I think NT-proBNP is only one metrics, right, of cardiac function, and one that can be affected, as Dr. Mukhtar said, by so many factors. So we typically put our patients through a cardiopulmonary exercise testing as a functional study to evaluate the cardiac reserve before we undertake the idea of stem cell mobilization and a transplant, and also to decide on full dose melphalan versus dose reduced melphalan in patients that are known to have AL amyloid cardiomyopathy. So that has been very helpful. We have had patients with stage 2 disease and 3A disease that got full dose melphalan actually on the base of really an exceptionally good cardiopulmonary exercise testing. And then I think that the major question, or one of the big questions in the field, is how do we see the role of autologous stem cell transplant currently, right, in the era of a highly effective quadruple therapy up front with many deep response, including MRD negative remission with DARA-CyBorD, and as well as many other options for salvage therapy that appear rather strong, particularly venetoclax and BCMA targeting agent. So a phase 3 randomized study of transplant versus no transplant after DARA-CyBorD induction sort of molded similar to the determination study in myeloma is actually being undertaken and in the making, and I think that's going to be crucial data for us to really have an educated discussion with our patients that is supported by modern randomized phase 3 studies.
Okay, we have time for just a couple more questions. I have two specific, I think, questions left, and then after that, you can see the QR code for the post-symposium evaluation, and I would encourage everybody, please fill that out. Also, we're going to that evaluation repeats the questions, the clinical questions that we asked, and that's how you're going to prove to us that we did a good job up here by shifts in our answers. So please fill that out. First question, I'm going to start with Dr. Abenauer, a practical question about the bleeding and clotting management. So in patients with nephrotic syndrome who are going to be started on IMiD-based therapy, does the presence of nephrotic syndrome, if they've never had let's assume they've never had a thrombotic event, does the nephrotic syndrome affect your thromboprophylaxis strategy in these patients?
So we mentioned that nephrotic syndrome does increase the risk of thrombosis. Now you add one agent that will increase the risk of thrombosis. So would I use aspirin only like we do in myeloma? I will be hesitant to do that. So I would probably consider ODAC in that setting, an oral anticoagulant.
What do others have a?
So I'm a bit on the aggressive side, I guess. I think we prophylax everybody with DOACs in patients who have nephrotic syndrome, even if they're not exposed to IMiD, because of the thrombotic risk. And we use full doses rather than prophylactic doses of DOACs, generally apixaban, in this patient population if they have an aggravating factor on top of just the nephrotic syndrome, whether they're immobile or they are on a therapy that is prothrombotic per se, or obviously if they have had a clot in the past. Those are all patients that are going to go on full dose anticoagulation, but we provide anticoagulation in the setting of nephrotic syndrome also only.
I think I follow what Dr. Abenauer does, like, the myeloma practice, that if you have one factor, you can probably satisfy yourself with antiplatelet therapy, but if there's more factors, then DOACs should be added. Immobility, if the patient has a neurological condition that is immobile, that is a risk factor, and so that's even before the IMiDs might put the patient on a DOAC.
In my own practice, I have to admit, I don't use DOACs automatically on the basis of nephrotic syndrome, just because review of the literature, it doesn't seem that all nephrotic syndrome is created equal. Like the risk in amyloid patients may not be the same as the risk in, somebody like with an IgA nephropathy or some other, some other cause of nephrotic syndrome. But I think that in patients who are going to be treated with IMiDs, when you have that plus, plus an IMiD, plus a prothrombotic therapy, I think that does make a lot of sense. And then what I struggle with personally is whether that should be full dose or some sort of low prophylactic dose. And again, my own practice, I'm just going to go on record, I guess, I tend to use a prophylactic dose, not full anticoagulation. So,
I just want to go on the record that I will not give DOAC to just patients because they have nephrotic syndrome. I really have to have other reason for that. Do they have cardiac involvement? Do they have atrial fibrillation? But are they just laying in bed all day long? But I think it's a little bit more aggressive than we probably should, especially if they have some GI involvement and they start bleeding. I think that will create more problems.
All right, and then the last topic that I wanted to sort of bring up in questions, there was a abstract that's been getting some attention from Dr., I want to make sure I get this right, from Dr. Zhang, abstract 536, an assay looking at homodimeric light chain constant domain fragments as a means of detecting a blood assay for detecting lambda light chain amyloid. Which looks very sensitive and specific. It's impressive data. And I think about that like in the context of other serum-based tests like glycosylated light chains, things that other things that have been looked at as maybe screening blood tests that we might bring to bear for patients with suspected amyloid, especially I'm thinking about like an MGUS patient who has neuropathy, where you do your workup, you've done your bone marrow, you've done your fat pad, it's negative, and you know that 10% of patients with amyloidosis haven't been picked up yet, right? And so how can we use these kinds of blood tests, or if we can use these kinds of blood tests to help us? Can anyone, I welcome anyone's opinion, does anyone envision them being just a diagnostic test that we do and use? Or are they the kinds of things that might factor eventually into some sort of machine-based learning algorithm where it's like if you have certain symptoms and this test is positive, it helps improve the accuracy, the positive predictive value of these kind of machine learning algorithms? I'm going to ask people what they think. It's a hard one, but this abstract was really interesting, I thought, and so.
So I think we need a screening test for light chain amyloidosis. The problem with this disease is the delayed diagnosis, not picking up too many patients that then turn out not to have it. So I think if you want to increase a bit, or restrict the pool of patients that we should screen with this kind of assay, if they're validated, will be patients who have an abnormal light chain ratio, for instance. So you sort of narrow it down to that patient category, missing hopefully very little patients that don't show up with an abnormal light chain level or kappa lambda ratio, or obviously the presence of red flag symptoms. Last 2 years ago, a year and a half ago at ISA, there was data presented out of Pavia, right, about implementing NT-proBNP and albuminuria screening on all patients with MGUS and smoldering, picking up about 1% of patients with amyloid that you wouldn't have picked up had you not do that. So I really think efforts that move toward early diagnostic and screening procedures are critical in this disease. So I'm very excited to hear more about that.
Yes, a more general comment is that we need also for transthyretin amyloidosis the identification of misfolded species that can predict, for example, conversion for presymptomatic carriers to affected patients, or can help us monitoring response to treatment, because in ATTR amyloidosis we are far behind the light chain amyloidosis in the sense that we don't still have a marker of response to this treatment, because also the mechanism of action is completely different. You can either suppress, and in this respect we have roughly threshold for considering the patient's responder, but stabilizers are known to increase the concentration of circulating TTR. So we still don't have TTR as a biomarker for response. In that case, it would be particularly interesting to measure the ratio between misfolding TTR to stable TTR in order to understand what's going on. So all these tests, I think, are quite welcome.
Right?
If I may say, sorry. Yes, please.
Nothing.
I'm involved in this work, so I'm a little bit biased, but I think that we have good screening for amyloidosis. This assay, if it will be proven effective, it's really for confirmation of diagnosis. We really need to work across all monoclonal gammopathies to see if it's really, has a good negative and positive predictive value, so we won't make mistakes, because we are making mistakes with amyloid all the time. We are developing clinical guidelines, and we kind of falling always in the traps of amyloidosis. So I think we have good screening, but obviously it can improve, even if it won't be a confirmatory test. But it will be amazing if we have an assay that we can do it from the blood that will tell us if the patient has amyloidosis or not. So
I agree, a holy grail type of test, right? I mean, that's I think what we would all really like to see.
and it's only lambda, so that's a caveat.
It's limited, right, limited lambda so far. Okay, we are over time. Thank again all of our speakers, fabulous discussion today, and thank you to our sponsors and also to the audience. We had incredible attendance today, and I appreciate how many of you stuck it out the entire time. Thanks so much.